Hi, this is Fernando Gomez Sancha. After a while, I wanted to show you, because there's a lot of interest worldwide, a MiLEP case. There's a German company that has produced this 22 French endoscope as well as the nephroscope with very interesting ideas, improving the flow in small spaces, and of course reducing the caliber in collaboration with Dr. Felipe Figuereido from Brazil. And it is generating a lot of interest, and I wanted to show you. I spoke to the company, they loaned me some equipment to try it. I don't like the trigger, you know, that I use my fiber with the fingers, and I think the trigger makes things a little bit more difficult, in my opinion, although many people are used to it. But I'll show you this case. This man had a catheter, he had a lot of bladder edema, he was on retention, and he had a mid-sized prostate that I chose for this opportunity. And as always, we're going to be able to see this MiLEP equipment in action, but also of course, we can refresh some of the tips and tricks that I usually use. So typically, you know, when I want to do the white line, I mark the limit of the sphincter, and you can find it easily on the sides, probably 9, 10 o'clock on the right side of the patient, and probably 3 to 2 o'clock. I do my first mark there, and then I take that as a reference to go up towards 12 and to go down towards 6 o'clock, keeping in mind that often the sphincter is a little bit tilted anteriorly, so the anterior part of the sphincter is a little bit more proximal than the posterior part. Also, as we know, the sphincter has a horseshoe shape that makes it more important to preserve anteriorly than posteriorly. But here we are. This is the entry, and as you can see, I'm using the magneto system with a virtual basket at 2 joules 50 hertz, which is my usual setting, and I have the magneto setting just for coagulation. Again, here I'm going to the floor of the verumontanum to look for the entry to the interface, to the plane between the adenoma and the capsule. I don't give it much thought at this stage. I just go in and try to find a depth that looks satisfactory, but I don't lose time trying to find out, you know, where is this mysterious, beautiful plane. As you know, we cannot see this beautiful plane so much when we use these new lasers, because they provide very good first pass hemostasis. But that's the most beautiful, I think, you can see with these lasers. You get to see sometimes signs that you are in a nice interface between adenoma and capsule. There I'm cutting the frenulum of the verumontanum to connect both lateral spaces that I have open, and I'm starting now to develop the posterior line, as I usually do. Remember, I think of the prostate like a little box, so I talk about the posterior plane, the lateral plane in both sides, and the anterior plane. As you can see, I always put my scope aligned with the line of dissection. So in this case, I want to have the line of dissection in the middle of the screen to be able to move from side to side and develop this posterior plane. So here you can see that so far so good. We are seeing that there's a nice detachment of the plane as we progress from the verumontanum towards the bladder neck posteriorly. The endoscope feels very light. It is nice, and I think the endoscope, the enucleoscope, or the laser cystoscope that Felipe and this company have produced. I think it's wonderful in the sense that with a very small caliber you can do a normal job. Felipe is saying that he can do any size of prostates. I probably it's true. You have to realize that with these new lasers, the quality of the first pass hemostasis is very good. So the demands for irrigation, I think, are less. And also, if you do an Bloc technique, we are irrigating, a very small space, and you don't need a huge amount of irrigation power to be able to exchange the amount of water contained in this very little space that we are forming between the adenoma and the capsule. So really, I think the irrigation and the view and the maneuverability of this scope is excellent. So I have to say I like it, and I think it is truly interesting how you can use it for cases where, those cases where the urethra is smaller. I think this is opening new possibilities of being less invasive in these patients. We're going to publish a review of a retrospective review of 750 patients or something, and I have to say that our rate of strictures using the 24.5 and 26 French endoscopes from Richard Wolf are extremely low. I have to say also that I'm very, very careful using the Otis for the navicular urethral difficulties when I have to enter and I find the slightest tension at the meatus. I would do a very gentle Otis urethotomy, and I have to say that we see very, very rarely we see strictures at the meatus afterwards. And then when I have the difficulty entering near the sphincter, I try to use a progressive dilator, plastic progressive dilator that helps me enter very, very gently. I'm always extremely gentle during the enucleation and during the introduction of the endoscope. But of course, there's always cases with tiny urethras, urethral lumens, and I think the 22 has come to occupy a space that was not occupied by any other laser before. This is the 12 o'clock fibers. You saw that I ascended from 6 to 12 in both sides, and now we are connecting anteriorly, trying to remove all the anterior tissue, that we can find. So I don't try to leave tissue at 12 o'clock. I try to be as aggressive as possible. But of course, you have to understand that before, or many people who do an encircling technique to go up to 12 o'clock are going to need to be careful to see where they cut and how much tissue they leave, because typically they have produced this mucosal flap at 12 o'clock, and of course the flap is much more distal than our limit, or the limit I mark of the sphincter at 12 o'clock. So this is an interesting thought. And here you can see that I am now developing the anterior line. So we had a posterior line. We developed both lateral lines a little to be able to mobilize the apex and to come up towards 12 o'clock and connect and complete the early apical liberation. And now I'm doing the anterior line detachment or this dissection. It's important, if you want to reach the bladder neck, you have to put your scope on top of the adenoma and bring the adenoma downwards a little bit. And in order to have the mobility of the adenoma to do that, you have to cut these lateral attachments. You see, this is the lateral fixation that is going to fix the prostate and make the dissection of the anterior plane very difficult. So here I'm checking that the lateral plane and the lateral fixation at, I don't know, 10, 11 o'clock is being released, cut, so we can mobilize better the adenoma. Sometimes I get a little bit distracted in the posterior area. You see, I'm seeing this yellow stuff. So I'm realizing that maybe there is more adenomatous tissue than I thought. Maybe the plane I followed was not deep enough. So I am never shy to explore below the yellow tissue. And usually I find that I can remove more adenomatous tissue. Often these are nodules, adenomatous nodules that grow into the peripheral zone, and you see, whenever I see yellow, I try to explore and see if I can remove some more tissue. So I got a little bit distracted here, but the objective was to continue anteriorly. So let's see if I get back on track here, coming up again, trying to release these lateral attachments. We call them hammock attachments also, because when you put your endoscope at 12 o'clock, you see they act like hammock attachments, and they don't let you lower the adenoma with your endoscope. Of course, I never do force. This is the other attachment. You see, lateral fixation on this side. And now when we cut this lateral fixation, when we put the adenoma on top of the endoscope on top of the adenoma, we can access the bladder neck much more easily. So there, you see, don't try to go all the way to the bladder neck anteriorly without having cut this lateral fixation. You see, now the prostate gets progressively more mobile, and you can push it a little bit downwards, and that will allow you to enter. In this case, this instrument in particular had a very tough, very stiff trigger. So even when I wanted to use it, it was a little bit difficult to push it in. It was like fixed, and I had to do a harder push to the trigger, and so it was not properly, how do you say, lubricated, maybe. So maybe it needs to be used more often to soften or smoothen that movement. But now we have entered the bladder, and that's the bladder neck, and you see, I find much easier to use the fiber with my fingers. I have a lot of sensitivity. I can push the fiber in and out, and this will help me find the working distance that I want in order to, do my dissection and find the effect I want to find at different stages in the operation. Here, for example, when I get closer to the bladder neck, typically I want to be closer to the tissue, because here what we want really is to perforate. And so many times you can do a little bit of touching, you see, and cut the mucosa and open the bladder neck. And you see that the trigger is jumping a little bit, very difficult to control. So not ideal. And here in the posterior area, I started questioning myself, is this a nodular prostate? Am I finding here that I found a plane that looked good, but could I be going deeper? And I'm never shy to explore this possibility, because very often, I find that we can find a deeper plane that can help you remove a lot of extra adenomatous tissue. I don't know if sometimes, by exploring, you go deeper than, the proper plane. But in my experience, I am usually more happy to explore and to question my depth of dissection, trying to go deeper when I find yellow stuff that looks adenomatous, than, regret it. So I usually explore and try to see how far I go, trying to be aggressive, removing all the adenomatous tissue. If we leave adenoma, of course the adenoma grows. It's a benign tumor, so we want to try to be as aggressive as possible, removing this adenoma to prevent it from growing in the future and causing trouble. Some people say it's not important because the cavitation is still very good, but I mind, I want to be, and also I have a lot more fun if I am looking for these deeper planes very carefully, using the energy very softly and carefully. Now I have to say that this MiLEP instrument allows you to operate quite nicely. It feels very light, and I'm going to wait to get one when I can have a freestyle, board, because I hate the trigger. So I know that some people are very used to it and they defend it. To me, the main problem of the trigger is that when you give a trigger to someone who has already done TURP, he's going to try to use it like a resectoscope. So he's going to be rotating. He will have the fiber at 6 when he's at 6 in the adenoma. He will have the fiber at 3 when he's at 3 in the adenoma. He will have the fiber at 12 when he's at 12, and so on. So, and you see that I use the fiber very statically at 12 o'clock for most of the operation. I also work sometimes at 6 o'clock, but what I don't like is I don't like to rotate while I dissect, because I think that movement is much more complex than what I'm doing now. You see, when I follow a line, it's very, very precise. It's a very precise movement, and that is going to help me, I think, much better to be precise and to be able, of course, of exploring these deeper planes, playing with these ideas and safely, and the movement is more pure, more simple. And also, if you look at my hands during the operation, you will see that they're very static. I just move around the fossa, following these lines that I draw all the time around the adenoma, but I am not rotating the endoscope. I don't have to hold the camera so it doesn't rotate. So it's a much more simple manipulation strategy than the trigger, or what the trigger makes you do. Of course, you can use the trigger like this. I mean, not rotating, but the problem is that I don't have much freedom because usually I can push the fiber in and out very subtly to get the tissue effect that I want. So this is posterior, and the case is nearly finished, but I am still, let's say, trying to find out. You see, what is this? This looks like a nodule. That's a lot of adenoma left. Maybe even there is a little bit closer. That's a nodule. You see, it's digging a little bit deep in the capsule, and I want to explore that depth to see if I can remove the whole nodule and not leave it there, cut and attached to the capsule of the prostate. So there I am. That looks like yellow tissue. So I'm trying to find, you see, where's this yellow stuff, yellow tissue, adenomatous tissue. And I'm trying to connect, because of course you don't want to do many cuts on the prostatic capsule and have 4 parallel lines, and then you don't know which line is which and where do you have to go. I want to generate lines that I can recognize later, that I can connect with other lines, and try to work in an orderly manner, and carefully. Here you see we're getting a little bit deeper in the capsule. It looks thin, but it looks okay. So I think that's the nodular bit that we were finding. And of course we have to connect the bladder neck, come downwards towards the midline, trying to be as thorough as possible, removing the tissue, trying to connect the lines. Let's see where we are. This can be a little bit confusing sometimes, but you see, I see this yellow tissue and I think maybe I should go deeper, try to remove that. 2, you see, that's the idea. This is probably BPH tissue. There's more nodular stuff there, so I'm going to come lower here. I have no reach if I keep the fiber at 12 o'clock, so I'm going to use some of the 6 o'clock position to try to raise this nodule up a little bit. Some people try to remove these nodules mostly at the end. So once they have finished the enucleation, they then go back to check if there's remaining nodules. I try to find out, you know, if that's a correct depth when I am there. Let's say, you know, if I realize that there's yellow tissue, I'll go to pick it up and try to, you know, explore a little bit more deeply that depth. You see, sometimes it's you see that you're getting deeper in the capsule, and sometimes you see signs of thinning of the capsule. But it's typical that when there's a nodule growing against the peripheral zone will get thinner. So here I am. I think I was starting to feel very happy that I did that, because you see that there is this yellow nodule on top of me. There you are, you see that nodule. So this is what we are digging and extracting, and there we are, trying to connect the lines. You see that there is a thinner plane below, but of course this thinner plane is strong enough. Remember that we see a very, very thin, I mean the everything we see on the camera is highly amplified. The fiber measures 0.5 millimeter, so you can tell that our field of view is probably 4 or 5 millimeters only. So whenever we see a nick in the capsule or a little hole or something, it's usually very small. But of course, I try to keep my energy close to the side of the adenoma in order to be able to dissect more. But that was my wife entering the room. Sorry. And you see, I try to keep the energy up so I can ensure that I cut the fibers that join the adenoma with the capsule, and protect the capsule. You see that nodule that we have removed, and now I want to connect the lateral aspect. You see, if I see that in some areas the capsule is a little bit deep, I will fire a little bit closer to the adenoma to correct my targeting and to avoid following the deep plane into a deeper plane. There we are. So in principle, for this first part of the operation, I think this instrument is very, very usable. I'm not sure how would I feel. I don't have as much experience with this instrument as Felipe has, but I'm not sure how would I feel doing a very, very large gland, probably. And what I'm thinking about this business of miniaturization of the scopes, we have seen the same with stones. You know, we went from percutaneous surgery with standard sizes to mini perc and ultra mini perc, and people were enthusiastic about it because it would be less aggressive for the patient, it would cause less trouble with the entry into the kidney and so on. But then I think there has been a, let's say, return to be sensible. You know? There are cases where mini perc is wonderful, and there are cases where people still use the standard instruments because the size of the stone is too big, you know, and then you don't need to suffer so much yourself trying to do a very difficult job through a very small instrument. So I think MiLEP is here to stay. I think most of us surgeons who do a lot of HoLEPs will want to have a smaller sized instrument, and I also think that we will probably still choose a little bit bigger scopes for very, very difficult cases. I don't know. This is my prediction of what is going to happen. So kudos to Figueiredo, and kudos to the company who did this endoscope. I think the endoscope is very good, and as soon as we finish our enucleation, we will be able to move on to morcellation, and that's a little different story, and you will see. But in principle, using this scope is very nice. It's a little bit delicate, it's small. If you use the smaller size 18.5 French, I think this is a much more delicate instrument. You cannot use very high power because even the tip, I mean, could be damaged by having this effect of the energy so close to it. And now this is the hemostasis and trimming phase. If I find tissue that looks adenomatous, of course, I will want to take it out. I want to make the capsular fossa as perfect as possible. And as I said, I didn't find any problem operating with this little instrument, except what my preference regarding the not using the trigger. I think the trigger, it's not so comfortable, and if you are very comfortable with the trigger, you should try to use your fingers, because it's a new feeling. And after some cases of feeling, a little strange without your trigger, you might find that the freedom you have is amazing, and the sensation, you hold the fiber with your fingers and you have a lot of control, and also it allows you to do this rotationless dissection, keeping the fiber at 12 o'clock during most of the operation. So here we have, you can see the mucosa of the sphincter is not suffering. It's not suffering from the cheese grater effect, or it's not suffering from the size, causing a little bit more ischemia. So all these factors, I think, are extremely reasonable, and also I find that the argument that Felipe gives to his patients is very convincing. He shows them 3 sizes of instruments, 18.5, 22, and 24, 26. And he says, which one would you like me to use inside your penis, and then the patients are horrified, and of course they want the smallest size. So that's an irrefutable argument. We all would want to have a thinner endoscope in our urethra. But as I said, we reviewed 750 patients, and the rate of stricture in our hands was very, very, very small. So I think there's no, and also there's no way to know if we will get less strictures when we use a smaller size endoscope. It is logical to think that. It is going to be difficult to prove it scientifically in a study, because if we have something that happens with a relatively low incidence, we will need to use huge numbers of patients to prove that there is a clear advantage of using smaller sized endoscopes. So I think the enucleation is finished, and the morcellation is going to take place now. And this is the change of instruments. I'm changing the laser cystoscope for the morsellation, but this morsellation, in order to have an overall small size of the sheath, and in order to have good irrigation, this morsellation has a problem, and that is that it uses a fiber optic lens. So this is like traveling to the past, when we did ureteroscopy with this kind of camera systems. So I think probably with this instrument, morcellation is going to be a little bit more tricky. There's people around using this instrument saying that they, let's say, suffer or struggle a little bit more, but they manage to do morcellation. But I think the reduced irrigation, Felipe says that if you use 2 inflows connecting, 4 bags with 2 lines as the inflow, if you use 2 inflows, you will get a similar irrigation as using a 24.5 from Richard Wolf using 1 inflow, which is what I usually use. But then there is this quality of the image problem. I have heard from some surgeons who are using these instruments that have, let's say, stopped morcellating with this device, and when they have to morcellate, they upgrade to 24.5 for morcellation. I'm going to give you a clip with the normal, or maybe I could insert it here, just a moment. So here I inserted a clip of a morcellation with a 24.5 endoscope, and you can see that the quality of the image is a little bit better using a proper rod lens than using the fiber optic lens. So here I think this is the weakest morcellation. I think if you don't have absolutely excellent hemostasis, you will probably not see so well because of the lack of visibility. When I have trouble with visibility, normally I use 1 inflow in my morsescope, and it's enough to keep it simple and finalize the morsellation. But I have to say that you can always insert a second irrigant, to get even better inflow when things get a little bit difficult. But overall, and I think now that the video is nearly finishing, I think that it is a step forward. It's a welcome option. As I said, I'm going to wait until the company produces a freestyle element. I'm sure that other companies will get interested in miniaturizing the instruments for HoLEP, as HoLEP is becoming more and more popular in the world, because you know that up to now it has been quite a niche operation, and that's why we have been abandoned by companies who have not developed new instruments for us. Also, they tell me that developing new instruments is a pain, as the regulations and the CE mark and FDA approval are a real pain and difficult. So for the moment, I'm going to stick with my 24.5 and 26. As I said, I wish I could have an instrument like this without a trigger, because the trigger makes it really unpleasant for me to work. But I think it's a great advancement, and we have to congratulate Figuereido and the company, the German company that has produced these instruments, that was kind enough to loan the equipment for me to try. And here, well, this is a video, and this is my opinion, and these are my ideas. So I hope you enjoyed the case, and see you around. All the best. Take care. Bye-bye.